Hi, this is DeWitt Wilkerson, and you're watching the Best Practices Show.
Hey guys, thanks for watching the Best Practices Show, where we take a look at the best business practices from the best dental practices all over the world. And today we're going to be talking about one of the hottest topics, if not the hottest topic in all of dentistry. You're already seeing this coming. It's the major shift ahead in dentistry with my good friend, Dr. DeWitt Wilkerson from the Dawson Academy. You do not want to miss this. So do me a favor, grab a pen and hit the share button. You're going to love this, and you're already seeing it. So this guy's a tremendous expert on this particular topic. Now, a couple show notes. We are shooting this live like we always do on Facebook. So if you're watching this and you're watching the live feed and you have a question, add it to the feed and I'll dish it to the master while we have him on, and I'll ask him the question directly and we'll get the answer straight from him. Or if you're watching them later on and you still have a question, continue to add your questions to the feed, because we want you guys to get the most out of this when you're watching this. Keep sending us suggestions for shows. I love all the suggestions. Even got a couple yesterday on this, on things that you guys would like to see. We're lining them up, and as always, appreciate the shares and comments and everything. Right now, we're up over 39,000 followers on Facebook, and over 150,000 of you have been listening on iTunes or hit the iTunes page, and I don't have anything to say other than thank you. So appreciate it. Now, my guest today has been a longtime friend of mine. I actually got my start, or one of my major starts, at the Dawson Academy, Dr. DeWitt Wilkerson. And so, Whit, thank you so much for being on. I really appreciate it, my friend.
Hey, Kirk, and happy holidays to you. It's good to talk to you in December.
Yeah, it is good talking. It's always good talking to you, my friend. I always learn a ton, and I've just enjoyed our relationship for years. And before we jump into it, you know, we're both have heavy hearts, and Dr. Pete Dawson, who's been an incredible mentor of ours, just recently lost his wife, Jodi. And so you guys are coming back from that, and just wanted you guys to know that our hearts and, you know, thoughts and prayers are with you guys in this time. So.
Oh, I really appreciate it, Kirk. And, you know, Jodi and Pete had an amazing marriage for well over 60 years. And it was a sweet time to see them together in her final days of going through over 10 years of Alzheimer's. And so it was a painfully long, you know, illness, but it was a sweet time because she maintained this beautiful disposition, smiling and laughing all the way to the very, very end. And Pete was just the best husband I've ever seen, and I'm just so privileged to know them both and to, you know, see their great life together. And so we all have been in prayer and support of Pete, but he's doing very well, and I thank you for bringing that up.
Yeah, and I could echo the sentiments. Pete's one of my heroes, and not only inside of dentistry, outside of dentistry. He's just a tremendous man. And, you know, his book, you had mentioned, A Better Way. Can you just tell us about it? It's actually available, you know, so if you want to see somebody with a life very well lived, this is a great testimony, not only to him, dentistry, his marriage, his faith, his family. Tell us just a little bit about that, would you?
It is such a must read, Kirk. Just came out on Amazon probably less than 2 months ago, A Better Way. Pete was approached about writing a biography, and as you would expect, he said, no, you know, I wouldn't want to do that. And they said, okay, well, let me ask you this. If you were to summarize what has been pretty much the philosophy of what has made you such an influential and successful person, you know, could you summarize it? And he said, oh, that's easy. My philosophy has always been, if there's a better way, then that's what we should do. Mm-hmm. And he said, that's you know, been something that's worked very well for me. So the biographer who was approaching him said, okay, why don't we do this? Why don't we write a book together, and you can explain what you mean by that and how that's worked out in your life personally, professionally, in every way. And maybe you can help other people through it. And it is a terrific read. Reads like a biography. It reads like a novel. It's a history of dentistry. It's the life of someone who has committed themselves to excellence from day one and has realized through the years that a lot of the things that happened to him that were good weren't just accidental, were really orchestrated both by his efforts and by God as he sees it. And so he explains that very beautifully, and his faith is well described throughout it in a very, I think, a powerful way. So it's terrific, and I really highly recommend the book to everyone to read. Great Christmas present or holiday gift.
Yeah, absolutely. And we posted a link here in the in the actual post itself, so you can check it out right there. I highly encourage you to buy it. Now, today, today we're going to be talking about the major shift that's ahead. Now, this is a very big deal. One of the biggest deals that's hit dentistry in a long time. But before we get started, two things. Number one, if somebody hasn't heard of you, can you just share with them a little bit about who Dr. DeWitt Wilkerson is, a little bit about the Dawson Academy, and then I always like to talk about the why before we get into the how. So just give us a little background.
Oh, sure, Kurt. I was fortunate to join Pete Dawson in practice in 1982, right out of school, down here in St. Petersburg, Florida. So I graduated from the University of Florida and joined Pete that fall. And, of course, it's been a great ride as we've watched not only Pete's seminars that have been taught all over the world, but then the Dawson Academy came out of that. And we've had over 40,000 dentists come to just St. Petersburg, but now courses are being taught in probably 8 or 10 countries around the world, including China and India and Europe and other places. So the whole concept there, and this really looks at the history of our profession very strongly, is that Pete became involved in the subject of problem solving, and that would have originally been related to occlusion and occlusal problems back in the 60s, and really took what Dr. Pankey and many others were teaching and fine-tuned it and developed systems that people could implement into their practices, and added to that restorative dentistry and managing temporomandibular joint problems as we began to understand those really in the 80s. And so that's grown into something that's become a real foundational learning experience for those that want to be those that are doing major restorative dentistry, problem solvers, the go-to people in their community. And so Pete's influence over the last 50 years has been, well, I don't think it's touched anybody that's, has a significant role in dentistry or leadership role. So that's my background, and I began teaching as soon as I was old enough to, and have been teaching for, probably almost 30 years now, here and there and everywhere, and have just loved every day of it. The background scene, though, to what we wanted to talk about today is that as we're now able to look back and see the progression of how dentistry has developed, back in probably the 60s, you saw a better understanding of occlusion, and you had many pioneers in that field that really helped us fine-tune the understanding of what dental occlusion looks like when people started saving their teeth. Of course, before that, it was mainly denture occlusion. But what do you do when people have their teeth their whole lifetime? That changed the whole conversation in the 60s. And then perio and understanding that shift that teeth can be saved and that you're not going to automatically lose them with aging, as everyone thought was true, and managing periodontal disease, where now, we don't make a whole lot of dentures and partials anymore. A person loses a tooth, you throw an implant in there, and we've got 95-year-olds coming in with all their teeth. That's brand new, and that's because of that past history. TMJ disorders began to be discussed and understood probably in the 80s. Then in the 90s, late 90s, we got more into aesthetics and the cosmetic revolution, you remember, where patients were calling saying, I need white teeth, and the dentist wants to give them A3, and they're saying, no, I'm talking about bleach shades. And so veneers and learning veneers, and then computer technology and what that's done since the turn of this last century, and what we can do now with digital dentistry and fine-tuning, the elimination of impressions and being able to digitally determine where implants will be placed, and even doing full mouth reconstructions that way is unbelievable. But the question then that we've been asking the last couple of years is, what's coming next?
Mm-hmm.
It's going to be the next big shift in our understanding of our role in dentistry as oral health professionals, and just the role that we have. And it's been really exciting to see how that's unveiling.
Yeah. And, many people have already seen this shift. It's one of the most popular subjects or topics in all of continuing education. As a matter of fact, your courses are booked out as far as you can see, and all of these. And it's the topic of how, not so much sleep, but airway, and all of how all that comes together. So give us a little bit of background on what are you calling it? And you even wrote a book on this, and it'll be out in the next couple of weeks on the shift. And it covers really 3 different fundamental, key points or paradigm shifts in dentistry. So walk us through that.
Well, I think the biggest shift is understanding that we're oral physicians.
Mm-hmm.
We're not dentists working on teeth. And then when people come in with medical concerns and things like that, it's kind of out of our league. That's got to change, because the medical system today is so, I don't want to call it dysfunctional, let's call it limiting to the physicians who want to care for people, but they're trapped in a system where they're seeing 50, 60 patients a day only for a chief complaint, spending 10 minutes at the most with them, giving them that prescription, and they're on their way. Meanwhile, our country is getting sicker and sicker and sicker, and our health is worse and worse and worse, and our children are unhealthy and our adults are unhealthy, and they're predicting this will be the first generation where the children will actually live shorter lifespan than their parents, even though we've got everything available to us to live a long, long time. So the initial shift is for dentistry to understand that we can be on the front lines addressing the healthcare problems that we see, that we actually can become engaged in helping people be healthier overall, not just orally healthy, more healthy, but truly healthy. And so the 3 areas that we've kind of pinned down, I'm calling this integrative dental medicine, because integrative medicine is looking at the whole person, not just at the x-ray or at the chief complaint, but looking at the prognosis of the whole person, of the future of the whole person, of the direction their health is moving. And so for us in dentistry, we can do that too. And in fact, we have more touch points, more contact, stronger relationships than the physicians are able to have at this point. I think the information is all out there, and patients are somewhat aware of it, the public is, but they don't really know where to turn for help. So the 3 areas of this integrating dentistry into medicine, or integrative dental medicine, would be, as I see it, inflammation and infection. So we understand much more about oral pathogens and their role in systemic problems, including atherosclerosis and cardiovascular disease. And it's not hard to do better. Patients are now coming in sent by their physicians before they have surgery to make sure their perio is healthy. Every dentist has probably had somebody sent in saying they're going to have a hip replacement, they're going to have open heart surgery. Let's make sure their gums are healthy. Let's make sure they don't have periodontal disease. But the lack of shift so far has been that in dentistry, we think that means cleaning their teeth.
Mm-hmm.
Everything's going to be fine if we just clean their teeth. I would propose to you, Kurt, that the future, the shift in our thinking should be no bleeding on probing. I don't care if there's pocketing or no pocketing, but if there's access to the bloodstream of periodontal bacteria or periapical bacteria through, abscess teeth, then you've got systemic issues going on. So I think that in the future, hopefully not long, we will be doing much more with salivary testing, looking directly at the bacteria that are involved, that are at elevated levels, and then going after them. Not just through doing root planing and curettage and things that only aggravate the billions of bacteria that are in our mouths and really don't eliminate them as sources of infection, but really determined to eliminate the source of infection through the therapeutic modes that we have available now. And
right.
So much more proactive in thinking about eliminating bacterial colonization that are harmful versus just trying to do root planing, to do better flossing, things like that that are important, but that really may not get to the root of solving the problem. And
Right.
so that's one thing.
Yeah, and one thought on that too, because I just have to piggyback on that train, because what we've had Bale and Doneen on here too, and the research that they show us, who wrote the book Beat the Heart Attack Gene, the research and the data that comes out almost every month. Whit, speak to this, because we used to be able to say it could be linked. Now we know it is linked through all of this in many cases.
There was a research article published in Circulation by a group out of Finland headed by a researcher named Pessi, P-E-S-S-I, and it was looking at blood clots from acute heart attack victims. They took those blood clots and studied under the microscope for oral bacteria, and they were packed with oral bacteria. Doing endarterectomies, where you remove plaque from the carotid artery, they looked under the microscope in a number of studies, and they were packed with oral bacteria. And so the linkage there is not just, well, maybe this is causing inflammation, and inflammation breaks down the immune system, and too much inflammation in too many places can cause issues. This is like, nope, we found the oral bacteria in the plaque, we found the oral bacteria in the blood clot that caused the heart attack, and is that oral bacteria part of the infection, the inflammation, that's causing these unstable plaques to break loose like a pimple into your bloodstream that causes a clot, and boom, you've got a heart attack or a stroke. So the relationship is powerfully evident. And I think that argument that, it's a weak linkage or a loose association, it should be gone. It should really, really be gone. And Bale and Doneen's book, Beat the Heart Attack Gene, has a very strong supporting position of the influence of oral bacteria on being a big dog, as Brad calls it, a big dog in the cardiovascular arena. And so that's exactly what we're looking at. And he, as a physician who's committed to reducing inflammation, quieting down the fire of inflammation that's causing all of these unstable, health conditions, he actually does salivary testing on every patient that they see to look for oral pathogens so that those can be attacked so that patients don't have a heart attack. And that's also true of periapical lesions. So endodontic lesions can be a potentially very important source of infection that can cause cardiovascular problems. So they've done a tremendous job as a physician team in looking at this and saying, hey, don't forget about the dental oral component of cardiovascular disease, because if you do, you're going to have patients having heart attacks that are taking all their meds and statins, and they're still going to have a heart attack because they've got infections flowing through their system that aren't being addressed.
Yeah, Dr. Bale was with us in Napa at one of our conferences, and he told us a great story. He said this patient, who is a very rich guy, was somewhere in Mexico or something, and wasn't feeling well, had some tests done. He was able to see them. And he said, get to a dentist. And the guy's like, I don't feel well. He's like, no, get to a dentist. And the guy goes, I'm not going to a dentist. And so Bale's secretary said, Dr. Bale would like to know where to send your flowers because you're going to die. And he's like, are you kidding me? So he went to a dentist, found out that I can't remember the condition, but there was severe infection going on here, and kept the guy from having an evident heart. I mean, he was days away from dying from a heart attack. So it's crazy. Now, I only say this because what an exciting time to be a dentist, because all these things that we thought, like, it's all coming together with. There has never been a more exciting time to be a dentist. Would you agree?
Oh, yeah, absolutely. Absolutely. And we all know, for example, and we've read the linkage between things like diabetes and periodontal disease. So there's another component of inflammation and infection. And so what we've started doing in our office is we're doing a simple little finger stick where we can look at hemoglobin A1C. It costs us almost nothing. Our patients are like blown away because one study that was done by Susan Maples up in Holt, Michigan, she took 500 patients as a beta testing site in her office and did finger stick hemoglobin A1C and found that over 20% of her patients had elevated blood sugar levels. Brad Bale said, I think it's higher than that on a national level. That will represent either pre-diabetes or diabetes. Pre-diabetics usually almost always become diabetics. And I heard Michael Roizen at the Cleveland Clinic, who's head of the Cleveland Clinic Wellness Institute there, say having uncontrolled diabetes or high blood sugar levels is like having shards of glass scraping the walls of your arteries all day long. You cannot be healthy and have uncontrolled high blood sugar levels, period. And so we see patients every day with inflammation showing up in their gum tissues that could be related to high blood sugar levels. It's very easy to find out if that's true or not. Who else is going to do that? Nobody.
Yeah. Nobody gets as much insight, has the time or the connection with people as dentists do. So that's
Let me add one thing to that.
Please.
I'm a restorative dentist. So I know the dentists watching are going, okay, we're getting kind of off base here from mainstream dentistry and where I make, my living. And the truth is, this doesn't take me any time at all. If I want to check somebody's hemoglobin A1C level, I just tell somebody to go run a finger stick and show me the report, you see, while I'm prepping teeth. So I want to make sure everyone understands that expanding our paradigm or expanding our model of complete dentistry doesn't mean that we have to quit doing what we do now that's most productive. And I think that's really important to understand.
Yeah, it's very important when you understand the importance of medical billing now. And we have a lot of fee-for-service dentists that don't take a dime of insurance, and they understand pre-diabetic conditions, a lot of these things that are extra complex. Medical insurance has to pay all of it required by law if they can show the story by the codes that this is a condition medically. So not to get off track, but Lori Owens, we've had her as a guest. It's incredible where dentistry's headed. So that's shift number one. Shift number two, take us down shift number two.
Well, I think shift number two would be the very hot topic of airway breathing and sleep disorders. Where we are learning so much now is that when we talk about sleep apnea, which has been the major subject in dentistry the last 5 or 6 years, that's really kind of the tip of the iceberg and kind of the worst case scenario. But there's many, many more people, I would say, that suffer from breathing challenges, from what's called upper airway resistance syndrome, where they may not stop breathing and record as having full-blown sleep apnea, where you stop breathing for 10 seconds or longer multiple times each hour throughout the night. And so some people are having things that are manifesting themselves that can relate to upper airway breathing challenges that can create stress in the body, a response of the sympathetic nervous system and stress hormones and cortisol, creating excitement of the heart and tension throughout the system, maybe even clenching and bruxing, which may be related either to those high sympathetic responses or to an effort to open your airway. We're not positive. But the point being is that those patients could go to a sleep center and get a sleep study and would come back negative. And you'd say, okay, well, good thing you don't have a sleep problem. But they could be struggling all day to breathe. They could be having allergies and congestion and problems breathing, children with swollen tonsils and just really a lot of issues, poor sleep, that's really dramatically affecting them, but not necessarily being identified. So I think we're going to see that there's a lot more people with breathing dysfunction, and with that, things like crowded dental arches, malocclusions, mouth breathers, tongue thrusters, bruxers, gastric reflux, all these things are going together. And we see these in a dental office where you see somebody come in and they've got erosion on their teeth and they're tired and their muscles hurt and they've got headaches and they're TMD patients. And what we're learning is a lot of TMD patients are really patients that have breathing and airway and sleep disorders that are being diagnosed as TMD. And we need to do a better job of screening and testing that, but it's not hard to do. Nothing we're talking about is hard to do at all. And so this is a huge breakthrough, and we're right on the front lines there because we're working right in the zone, already all day long. if we just have our eyes open to recognize some of the signs and symptoms, they're popping up everywhere. I'll tell you a real quick story that's funny. Pete Dawson was teaching a seminar one time about TM disorders and screening and recognizing these and how many people there are out there with these problems. And so old fella from Alabama walked up to Pete and he said, "Dr. Dawson, I ain't never seen any of them TMD patients in my practice in Sylacauga, Alabama." And Pete says, "Well, you go home and you start looking at the things we're identifying here for you, and I think you're going to find there's a lot more people than you think." Mm-hmm. And so, 2 weeks later, he and Jodi were asleep in their bed, and at that time the phone was on the bedside table on Jodi's side, on bedside stand, and it rang at midnight. And she answered it and listened for a minute, and she put her hand over the receiver and she said, "Pete, there's some guy on the phone. He wants to talk to you, and I think he's drunk." So he got up and walked around the bed and said, "Hello." And on the other end, this guy with a real southern voice says, "Dr. Dawson, they're coming out of the woodwork." Talking about all these TMD patients. Well, I have to tell you, Kirk, they're coming out of the woodwork as far as understanding and identifying and recognizing now breathing, airway, and sleep disorders, and all the multiple things that go along with that, that we see dentally, and we see in the signs and symptoms of TMD patients and those patients we see that are unhealthy. It's just a pandemic situation.
Yeah, and airway is not a flash in the pan or a fad in dentistry. This isn't something that's just going to come and go.
No. It's a shift, and there's much science behind this, and it relates strongly to malocclusions and resolving malocclusions and getting stable results. So you cannot do major restorative dentistry with excellence going forward unless you totally understand the airway concept and how that fits into the whole equation. It's super important.
Well, and everybody has kind of changed the way they look at patients now, because you can completely restore patients, but if they still can't breathe, I mean, what good have we done for them at all? And
orthodontics on somebody with crowded arches that are mouth breathers and tongue thrusters, and you can't stabilize it because the problem that drove that malocclusion may still be present.
Right. And so, I know some young dentists kind of struggle with where this fits in their practice, but you've been doing this a long time. And I've had some dentists that have been practicing for 30 years. So like the dots are all connecting. Do you know what I mean? Now that I know more, it's like, now I know why this is happening. Well, I'm seeing this. I've been seeing this for 20 years. Now I know what it is, how it works. And you had mentioned last time, or one of the shows, I mean, the rate in which kids are being written prescriptions for speed now because they can't focus during the day it is an epidemic that's happening. So
yes, yeah, for sure. But it's very exciting because we're learning things that many physicians that would call themselves specialists in some of these things are really not familiar with. So, we want to engage them in this discussion. This isn't about being better than anybody. It's about teaming up, to solve problems.
Right. And that's happening. You mentioned there was a conference you went to. We were talking before. It was in Las Vegas, the Integrative Physicians. You said there was over 1,000 physicians there?
Well, no, 1,000
professionals that were there.
So we just, I've been involved in the American Academy for Oral Systemic Health. We call it AOSH for 6 or 7 years. And this November, last month, we had a joint meeting with the American Academy for Physiologic Medicine and Dentistry. So started by Michael Gelb and Howie Hinden and a bunch of wonderful people that are involved in that all over the country, that started out as primarily an airway-focused or centric group. Now they've expanded and they're realizing all the things we're talking about. You have to understand allergies. You have to understand a whole bunch of other factors in order to even address just airway. So what we did was we had a conversation, decided to do something together. And then they had linked previously with the American College for the Advancement of Medicine, ACAM, which is the Integrative Physicians group. So the three groups came together last month in November, and we had 1,000 health professionals there, dentists, hygienists, physicians, who are interested in exactly what we're talking about. And it was a remarkable conference. We're going to do more of those in the future. But the point was the collaboration was so powerful to hear neurologists and sleep physicians and cardiologists speaking, and then a dentist and then a hygienist, all speaking together about things that they can do to help patients be healthier. And the collaboration of learning from each other is very exciting. So, I see dentistry elevating its game to the point where we can become seen as almost like primary caretakers for complete health and be recognized for such in a way that physicians and people in the medical field will look up to us as really solving problems and identifying problems in a very, very important way. So it's very exciting. I mean, this is an opportunity we've never had before.
Yeah, I'm excited too. And your courses are crazy booked with people coming from all over the world trying to learn more about airway and what to do. So let's talk about shift number 3, which brings it kind of all together.
Right. So the third shift that I see is the emphasis of where we in dentistry can contribute would be TMD and occlusion, because that's always been our specialty that goes beyond anyone else in the medical field. And it's very important, Kirk, that we don't throw the baby out with the bathwater here. So we've spent many, many, many years establishing the importance of a stable occlusion, of healthy temporomandibular joints, and the problems that can occur from those being unstable. So, for example, when we look at airway problems or occlusion problems, and we have someone with an anterior open bite, or they have a retrognathic mandible or maxilla as well, now the first thought would be airway. You've got an airway problem, you've got a tongue thrush, but we should be very careful that we don't throw out the idea that this could start with a joint problem. And so to skip over that and just think everything is airway is a mistake. And it's short, thinking. So Mark Piper, who I've worked closely with for 35 years, Kirk Schellis, who's a neuroradiologist up in Minneapolis-St. Paul area, they did a study several years ago where they were looking at patients that were retrognathic, anterior open bite, patients that were candidates for orthognathic surgery. And what they did was they did MRIs on 100 patients that were anterior open bite, class 2 orthognathic candidates. What they found was 89 out of the 100 patients that they imaged were off the disc on one or both joints, had deterioration and breakdown in their joints. The more severe it was, the more retrognathic, the more skeletal problems that they had. So we want to understand that there could be a little bit of a chicken and egg question going on here, and that is that when we see someone with crowded arches and malocclusions and class 2 and anterior open bites that could be driven by airway and breathing disorders, we also want to make sure that we recognize that an internal problem in the joint can initiate the same kind of process and come out with something that looks very, very similar. So just like we want to make sure we aren't calling ADHD every child that is struggling cognitively and et cetera, that it could be an airway and breathing and sleep problem. So we want to make sure that when we look at malocclusions and retrognathic type situations, that we don't automatically call it an airway and breathing problem and ignore the TMD or joint health. So that's a big thing that we have an expertise in that really no one else in medicine does. And as we're looking at these complex problems or developing problems that we see from early childhood all the way through life, we want to make sure that we're paying attention to the health of the joints, and also recognizing that you can have a skeletal malocclusion, that can affect airway. So that can go both ways as well. So occlusion isn't something we're just going to say we don't care about it anymore. We just want their airway open. And if they only end up touching on their front teeth for the rest of their life because they're wearing a repositioner sleep appliance, who cares? Well, it doesn't have to be one or the other.
Yeah.
And we want to make sure that we, as this model develops, and it is developing, I mean, we're all just crawling, we're learning every day, and this thing is exploding on us, and we're going to have to catch up to the information that we're excited about. But with that, we want to make sure that we develop a model that's a sound, structural, medical, model that we can have our patients healthy for a long, long time.
Yeah, I did get a question from Krupa George, who asked, what equipment technology is needed to evaluate occlusion in sleep cases? T-scan, do you have any thoughts on that overall subject? I know that kind of gets into the technology, but what would you say to that question?
Well, I would say that when we're screening patients, we're going to be thinking about all of these factors: inflammation, infection, airway, breathing, sleep, TMD, and occlusion. So we're going to look thoroughly at each one and ask key history and observation, clinical observation. And when we see red flags for any of these things, then we need to dig in deeper, because the bottom line, as I've always been taught, is diagnosis, diagnosis, diagnosis. We're not going to just treat people by the seat of our pants and hope they get better. We want to do things properly. So if we have a patient come in, let's say they're a TMD patient. I wake up in the morning, my jaws are tired. I'm getting headaches 2 or 3 mornings. I wake up with headaches. I'm clenching and grinding my teeth. My joints are clicking and popping, and maybe they have congestion in their mouth breathers. All of those things are going on. Then we want to look at all of them. So we could do a CBCT, and we can see the joints, at least the joint anatomy. We can look at the upper airway to some degree. We can look at the posterior airway. So an image of that type would be very helpful in getting a good idea. But if someone's got pain in their joints, that's not going to be enough information. Now we may say or they're getting structural dynamic changes in their occlusion where it's opening up in the front. Then we're going to want to get an MRI too, because we need to go in and look at the soft tissue disc. We want to look at fluid in the joint. We want to look at what's going on in the bone marrow. There's important information to gather. So that would be appropriate in that case. So yes, we can get a CBCT, but we may need an MRI as well. The bottom line is, what do we need to gather to give us an accurate diagnosis that will guide our treatment plan and what we will be recommending to people for long-term stability or correction? So that's just an example.
Yeah. Now you use the magic word, which is diagnosis. And I don't know who said this, but maybe you would, many years ago, I don't know who said it, but it was fantastic. While there may be many treatment plans, there's only one true diagnosis. Would you agree with that statement or not?
Well, I would say sometimes we have to use a differential diagnosis and then try some therapeutic steps to clarify it. And so I think there can be one diagnosis, but there can be more than one answer to that diagnosis, more than one factor involved. So we're not going to oversimplify it and say, oh, it's just your bite, or it's just your joints, or it's just your airway, and that's the diagnosis. It very likely today is a multiple factorial thing.
Well, I think it goes back to what Pete told me. His first piece of advice to me was, don't ever say you haven't figured out. He told me that 25 years ago, because the word diagnosis and what's truly going on and what we know now, it's kind of a moving target. And that's why education like this at such a great level is so important, because we know more, we can see more. And just like the dentist who said there's no TMJ or TMD, he went back and had different glasses on. Yeah. He was looking at the same patients, but he had different glasses.
Yeah, absolutely. And that's exactly true for all of these things. But here's what I feel. I feel excited because we've always been limited in what we could offer people. A patient comes in, they're clenching and grinding, they've got headaches, their joints are uncomfortable. We make them a splint. And we see how they do. And if they don't do great, we give them muscle relaxers, and then we throw some, bruxism medication at bedtime on it. And then we throw them to the physical therapist. And all we're doing is just kind of massaging the problem, but we really haven't gotten to the root of it sometimes. Now we're starting to understand more root causes, which means if we understand those, we can start reversing some of these things. And that's what really gets exciting.
Yeah, and you're unearthing some stones here, because we got some people chiming in, which are great questions from Arjun. He says, hi, Kirk and Dr. Wilkerson. This is great, and the DOS Academy has been accounting for airway issues since the past few years. What's your take on management versus treatment? Have read a few studies in which say it's the airway collapsibility that's the cause, expanding arches and creating more oral volume, and mobility of the tongue may or may not treat the problem. Also, do you believe in MAS or prefer oral appliance that may open the vertical rather than protrusion? What would you say to those?
All right. So initially, where we started with this, and most of the courses that are taught on sleep apnea, quote unquote, are about management, meaning people hate their CPAP, they don't wear them, they've still got sleep apnea. So what we're going to do is we're going to move the mandible and we're going to move the base of the tongue forward, get it out of the airway, open it up, and now they can breathe, and we've created the magic bullet for them that will solve their problem. Well, we know that's a management tool. Do they still have breathing problems, collapsibility of the airway? Yes, they still have all of that present. So that's a management tool, but it's not a solution, meaning a resolution. It's not reversing or stopping the problem. So it would be like saying, you've got diabetes, Kirk, so what we're going to do is we're going to give you a prescription. Okay, and we're going to monitor this, and we may have to up your prescription. We may have to protrude your mandible more through the years because it could get worse. And we're going to try to keep a lid on this problem. So that's managing diabetes or managing airway problems. But if I told you that 90% of patients that have type 2 diabetes can reverse it through lifestyle changes and bring their blood sugar level down to a normal level without medication, would you rather do that?
Absolutely.
If you're willing to change your lifestyle, to start eating healthy, to start exercising, to stop smoking, I mean, that's going to take a big commitment, but that opportunity is there. So I think that's right where we are with the airway, breathing, sleep disorders, is the fact that, yes, addressing upper airway problems, whether that's through ENT surgery or through dealing with the allergies that may be driving all the inflammation and correcting that problem, or perhaps in some people where it won't be resolved through reversing allergy symptoms and nasal breathing, we may have to remove tonsils or do a tongue tie release or expand the dental arches. Those are all possibilities for trying to create a better volume for the airway or a better system for the airway, or enlarging the size of the airway tube, as it were. Now, I think we talk about we're just crawling. Let's be honest. Do we know for sure that if we do arch expansion that your airway problem is going to stop? I mean, can I tell you that before we treat you, that you will be better? And the answer is not yet. Not yet. And there are a lot of things. I was just up in Calgary with Dr. John Rimmers, who is one of the fathers of sleep medicine, and he has developed a tool that we've just started using in our office I'm very excited about, called a matrix. It's been around for a little while. It's upper and lower trays that connect together. You reline them with bite registration material. The patient sleeps, and remotely they can move the mandible forward while the patient's sleeping and monitor whether it improves their airway, whether it reduces their sleep apnea, whether it stops their sleep apnea and snoring. And now you can even do it in such a way where it can find the therapeutic position, where if you're going to use an oral appliance, this is where you would want to put it to get the maximum improvement.
Wow.
So, but listen to what they have found in their work in Calgary. About 70 to 80% of patients that have an oral appliance titrated in their mouth during sleep actually get significant improvement. About 20 to 30% get little or no improvement. So what we're saying is that there's thousands, if not millions, of oral appliances being made for sleep apnea every day, or not that many every day, but there are that many out there, all right? But the fact is probably 70 to 80% actually are therapeutic. And so one of the arguments that some physicians would have is, well, why would I send a patient to a dentist to make an oral appliance for them, and I don't even know if it's going to help my patient or not? I think that's a really good question. isn't that the question we should be asking? Is, if I make you this, will it actually help you? And right now, the answer has been maybe. And after we make it for you, we're actually going to come back and we're going to retest you with the oral appliance in place and validate that it has helped you. But we're really not sure until we try it. Okay? So, is there a better way, as Pete would say in his book? And the better way would be, I think, what Dr. Rimmers is talking about, and that is, let's prove whether it's going to work or not before we commit to that therapy. And it sounds like that's possible now. And I think that will be something that will become very commonly used going forward. So the question that was asked was about managing versus treatment or resolution. And I would say, managing is where we probably need to start and say, if we can improve your airway tonight and reduce or eliminate your sleep apnea, that's a great direction to go. Whether it's using a CPAP or an oral appliance, if we can do that. It's going to be even better when we know we can help you and we can help you this much before we start. But then also with that would be the thought, after we are able to get control of this problem, that if you have moderate to severe sleep apnea, and we really don't want you going tonight with that if we don't have to, so we want to do something right away. The next question is, would it be possible, Kirk, to actually reverse it, and correct it, and working with our ENT specialists, or working orthodontically, or working with the myofunctional therapists, and getting the mouth closed and breathing through the nose, and learning how to properly breathe and swallow and position the tongue. All those things can be very, very therapeutic. But I hope that in the future we're going to have a better idea of predictability, which, we don't have right now, but it doesn't mean that we should just not do anything. But I think that's the direction that we'll be headed in going forward.
Yeah, this is so great. And Whit, I love this conversation. And a lot of the literature, even your literature, you're going in the direction not only educating dentists, but also patients, because we're seeing that swing too. Can you speak to that?
Oh, yeah. Well, patients don't really have a hard time understanding what we're talking about because it just makes sense. When you say, hey, breathing is like number one, and if you're suffering with stuffy nose, or you recognize that you're a mouth breather, we can show you these different, you're tired all the time, whatever it might be, that's super critically important. And this can be driving all that. So the patients are very responsive. I think they're very responsive in the inflammation area too, and understanding that bacteria in your mouth can be a problem everywhere. They understand that. And so I think that the shift isn't so hard for patients, I don't believe. I find that they're very interested in these discussions, and it's just a matter of explaining it to them. The direction I'm going in is trying to explain to the patients and the public that these things you can get help for, and we're trying to point them to the dental profession, the dental office, for help. Now, what's going to happen, I hope, is that patients are going to start calling saying, do you do salivary testing? Do you work with eliminating oral pathogens in my bloodstream? Do you evaluate airway and TMD and stuff? And that the dentists are going to have to respond and say, sure. And then they're going to have to learn it. Have to learn this stuff real quickly, because the public is going to be driving it just like they did with veneers and, California white teeth, which the dentist would have never come up with that. But we learned to do all these things because the demand was there and we had to respond to it. Or get left behind, And that's what I'm hoping is that there'll be that kind of that pressure on all of us to not get left behind and to learn these things, which we may think, oh, that's medical, and I don't know if I really want to get into that. Yes, we do want to get into that. And I want to look at a patient's health history and see these positive signs going on in their system, and not just say, gee, I hope you got a good physician because you sure got some problems. But rather say, you know what, we can help you, or our team can help you, or we're collaborating with help, and we're going to guide it. We're going to be on the front lines as your advocate for health, And when that goes way beyond dentistry, you know what happens, Kurt? The patients come back, and when you talk to them about their dental needs, you know what they say? fine, whatever you say, because I know you care more about me than I care about me already. So if you're recommending I need dentistry, I must need it, because you wouldn't recommend it otherwise, because you are no used car salesman. You know, you're the guy that's loving on me like nobody else ever has. Therefore, my trust level for you is complete.
Yeah. So this is so great, Arjun. And, you know, I heard Pete say this, there are people that change lives and there are people that fix teeth. And this is the classic differentiators. Arjun just wrote back. He said, thank you so much for the insight. This is an interesting time to be providing dentistry, especially because we could affect the general health of a patient in a really big way. I wish we could fast forward to 10 years ahead. And I would love to stay really predictable with airway, very similar to how Dawson 2D and 3D checklists help provide that.
Yes, absolutely. Right on.
Yeah. So I just have one of my favorite questions to ask. Like, you're a world-class educator. You've educated thousands of dentists. I'm out on the road. I bump into you in airports. You're speaking to study clubs. I mean, you're educating thousands of dentists. If I'm a 32-year-old dentist watching this, because we watch the metrics, we have a lot of dental students watching this, and I'm trying to make sense of this. What would you say to the young 32-year-old dentist that's watching this right now?
Yeah. Well, I would say this is there's never been a better time to be a 32-year-old dentist. My only regret is I'm not a 32-year-old dentist. But I'm going to keep going as long as I can, because I like golf a lot, Kirk, but I like it half as much as this. And I have no desire to ever walk away from dentistry and say, I've done my thing, because there's too many lives to impact. So with that, we're right on the cusp of breakthroughs, I think, where it's going to become more general consensus and not outliers that are having this discussion. I love the fact that this fall, thanks to Steve Karstensen, they had this major meeting at the ADA headquarters in Chicago on children's airway and breathing disorders. They're doing another one in, I believe, April there. And so, we got the ADA now starting to kick the tires a little bit on these things, and it's all going to start syncing together very beautifully. So, I would just say this is something I would really pursue if I was a young 32-year-old dentist, is being who I am. I'm an integrative dentist. That is, I'm concerned about your whole health. And so start with understanding what can be done to optimize periodontal health. That's an easy one, and the answers are there. Learn about occlusion and airway and temporomandibular joints. And focus, and it's all going to lead to restorative dentistry and orthodontics and the things that are very productive, because those are part of the answers to stabilizing many of these things. So it only adds to being a busier restorative dentist, or being more successful in what you do and more productive in what you do. So there doesn't need to be any fear of that. But I would say just keep your eyes open to all these new things, and there's conferences and learning opportunities all around us, and it's going to explode now. I was talking to Joan Forrest last year, and I said 2018 is going to be a big year, and she's the CEO of the Dawson Academy. I said, because these things are starting to really stick now. This isn't a fad, and we got to get on board, because the train is pulling out right now, and it's not, you don't want to be left behind. Yeah,
absolutely, buddy. And now I know we only have you for a few minutes, and you got to run, but your book is coming out. It's called The Shift, and that'll be available in a couple of weeks. I highly recommend you, if you're watching this, check it out. As soon as it gets posted or released, we'll have it on here. So check that out. And then also, I highly encourage you, if you haven't been in the Dawson Academy, you got to go. A really amazing, special group of people. And then Whit, I would say this about you: if you're looking for a speaker to come to your study club that knows, this guy knows a ton, and I would highly encourage it. So Whit, for the benefit of people that are listening on iTunes, how can we get more information from you or learn about you?
Oh gosh, I guess just give me a holler. You can reach me at DWilkerson at thedawsonacademy.com, and we can talk some more. If there's anything I can do to help anybody, if they have questions or family members. One of the things I'm seeing so much now, Kirk, that's been so rewarding. I've been out on the road teaching TMD and occlusion and restorative dentistry for 25 or plus years. In the last 2 or 3 years, as we've started focusing on this integrative dental medicine model, it's been a whole different experience, because every break, at the end of every session, during lunch and at the end of the day, there's a line of people coming up saying, what about my 5-year-old? What about my husband? What about me? What about that patient I saw yesterday? Who do I refer to in my community? What do I do? And it's just this huge personal thing that I'm finding, that everyone knows something or someone or themselves that has an issue that they consider major. They're looking for answers. And so I'm just so excited about that. And I'd be happy if you have a family member yourself that you have questions about, just reach me through D. Wilkerson at the Dawson Academy. I'd be happy to email with you and converse with you any way I can help.
Well, buddy, we're so grateful for all your time, your friendship, and please give our best to everybody at the Dawson Academy. And we can't wait to have you back again. So stick around while we say goodbye to everybody else. And so thank you guys for watching the Best Practices Show. If you enjoyed today, which I know you did, just do us a favor, hit this share button and share it with your friends. And protect this great profession we call dentistry that we love so much. And keep sending us suggestions for shows, things that you'd love to see with Whit or anybody else. We'll line them up and get them to you soon. And until we see you next time, keep watching the Best Practices Show. You guys enjoy the rest of your day.